Good to have you here. This session covers cardiorenal syndrome, bridging nephrology and cardiology.
To truly bridge the fields of nephrology and cardiology, we need a clear roadmap. This session is designed to provide just that, by answering the fundamental questions that define our clinical approach to this complex syndrome. First, how does cardiorenal syndrome actually present? It's not a single entity. We'll dissect its 5 distinct subtypes, clarifying how the direction of organ injury, whether the heart fails first or the kidney, radically changes the clinical picture and our initial management priorities. Then we'll explore the shared biology. Think of the heart and kidneys as being connected by a busy two-way street of physiological crosstalk. We'll uncover the common culprits driving dysfunction, from neurohormonal activation and hemodynamic instability to systemic inflammation and oxidative stress. Understanding these pathways is the key to targeted therapy. Of course, in a busy clinic, we need to know who is most at risk. We'll discuss how to effectively stratify patients using a combination of clinical judgment, imaging, and key biomarkers. This is about identifying the subtle signs of decline before a patient decompensates. And what do we do once we've identified these patients? We'll review the evidence-based strategies that have fundamentally changed outcomes. The focus has shifted from treating one organ in isolation to using therapies like SGLT2 inhibitors that offer integrated cardiorenal protection. It's a holistic approach that truly works. Finally, we'll place our practice in a global context. While major U.S. guidelines from the AHA and ACC provide our foundation, we'll see how international bodies, such as the European Society of Cardiology, offer complementary perspectives, reinforcing a unified global effort to combat this condition. With this framework established, the question becomes, just how profound is this intersection of heart and kidney disease in our patient populations? That's the critical challenge we'll tackle next.
We've just reviewed our learning objectives, and this slide really gets to the heart of why this topic is so critical for modern clinical practice. Cardiorenal syndrome isn't some rare, esoteric diagnosis. It's a common and formidable challenge we face every day on the wards, affecting millions of patients. The data consistently shows that when significant cardiac and renal dysfunction coexist, both morbidity and mortality rise dramatically. This isn't just an additive risk, it's a synergistic one. The real danger lies in the therapeutic tightrope we have to walk. Mismanagement, even when well-intentioned, can create a vicious cycle. For example, aggressive diuresis to relieve pulmonary edema and heart failure can reduce renal perfusion, triggering an acute kidney injury. This kidney injury then promotes fluid retention and neurohormonal activation, which in turn worsens the heart failure. What we commonly see is this cycle accelerating disease progression and leading to that revolving door of frequent, costly hospitalizations. Every decision we make in these patients has consequences that ripple across both organ systems. Choosing the wrong agent or the wrong dose doesn't just lead to a suboptimal outcome, it can actively cause harm. This directly translates into longer lengths of stay, higher rates of readmission, and a significant economic burden on our healthcare system. The financial impact is immense, but the cost to patient quality of life is even greater. Herein lies the central dilemma for us as clinicians. The very therapies that support the heart, like certain afterload-reducing agents or diuretics, can potentially threaten the kidneys. Conversely, strategies to protect the kidneys, such as cautious fluid management or avoiding specific medications, might compromise cardiovascular stability. Balancing these competing priorities requires a profound understanding of the underlying pathophysiology. To navigate this complexity effectively, we need a more structured approach. So, how can we begin to categorize these intricate interactions in a clinically useful way?
So, to effectively manage this complex clinical challenge, we need a clear framework. That's where this classification system becomes indispensable, giving us a common language to describe 5 distinct subtypes of cardiorenal syndrome. The core principle is that there's a primary offending organ, either the heart or the kidney, that initiates a cascade of damage in the other. Let's start with the heart as the primary driver. In type 1, an acute cardiac event, like decompensated heart failure, triggers a sudden drop in renal perfusion, leading to acute kidney injury. In practice, this is the patient in the ICU, whose heart attack is now causing their creatinine to spike. Type 2 is the slow, chronic version of this story. Here, a patient with long-standing heart failure experiences a gradual, insidious decline in kidney function over years, culminating in chronic kidney disease.
Now, the causal arrow can point in the opposite direction, from the kidney to the heart. In type 3, an abrupt insult to the kidneys, think acute glomerulonephritis or rhabdomyolysis, causes acute cardiac dysfunction, such as heart failure or arrhythmias, due to volume overload and uremic toxicity. Similarly, type 4 describes the cardiovascular consequences of chronic kidney disease. The persistent anemia, hypertension, and mineral bone disease associated with CKD place an enormous chronic strain on the heart, leading to hypertrophy and accelerated atherosclerosis. Finally, we have type 5, which accounts for systemic conditions that cause simultaneous injury to both organs. A powerful example is sepsis, where a systemic inflammatory storm and hemodynamic instability can induce both acute cardiac dysfunction and acute kidney injury at the same time. Severe diabetes mellitus is another key example, where the underlying disease process damages both the heart and kidneys concurrently over a long period. This classification gives us a vital starting point. It tells us where the fire started. But once that initial injury occurs, how does the damage cascade and spiral? What are the specific pathophysiologic mechanisms that create this vicious cycle of decline?
After mapping the different subtypes of cardiorenal syndrome, we can appreciate it's not a single disease. But regardless of the starting point, the underlying story of progressive organ damage is remarkably consistent. It's a story of crosstalk, of a conversation between two vital organs that turns destructive. It all begins with an initial insult. Picture this: acute decompensated heart failure strikes. This doesn't just impact the heart, it sends out an immediate system-wide alarm. Neurohormonal pathways and inflammatory cytokines are activated, and the kidneys are among the first to receive this distress signal, triggering a reciprocal cascade of injury. The key players in this destructive conversation are the renin-angiotensin-aldosterone system, or RAS, and the sympathetic nervous system. In the short term, they're simply trying to preserve perfusion, but their chronic activation is toxic. This relentless signaling drives fibrosis and hypertrophy, essentially remodeling both the heart and the kidneys, making them stiff, inefficient, and prone to further failure. Here's where it gets very challenging in clinical practice. As renal function declines, the body's ability to clear medications is impaired. A standard dose of a beta blocker or an ACE inhibitor that was once therapeutic can suddenly become toxic. We're constantly walking a tightrope, trying to manage the cardiovascular disease without inadvertently worsening renal function, a risk that complicates every prescription we write. This creates the devastating feedback loop you see illustrated here. A worsening heart reduces blood flow to the kidneys, impairing their function. The failing kidneys, in turn, can't manage fluid and electrolytes, which increases the volume load and puts even more strain back on the heart. It becomes a vicious, self-perpetuating cycle of decompensation, where each organ's failure accelerates the other's decline. This downward spiral of organ dysfunction presents a profound clinical challenge. The critical question then becomes, where are the points of intervention? How can we effectively disrupt this vicious cycle and stabilize the patient? The downward spiral of organ dysfunction we just saw can feel inevitable. Fortunately, we're now in an era where we have a powerful, evidence-based toolkit to break that cycle and rewrite a patient's trajectory. The evidence is clear on several key therapeutic classes. First, the SGLT2 inhibitors. These drugs have been a revelation. Initially developed for diabetes, we now know they provide profound cardiorenal protection regardless of a patient's glycemic status. In practice, this means we're seeing dramatic reductions in heart failure hospitalizations and a significant slowing of CKD progression across broad populations. They offer a dual benefit that directly counters the pathological crosstalk in cardiorenal syndrome. Next are the mineralocorticoid receptor antagonists, or MRAs. Think of these as blocking the downstream damage caused by aldosterone, reducing the fibrosis and inflammation that stiffen the heart and scar the kidneys. The clinical result is improved cardiovascular outcomes, particularly in heart failure with reduced ejection fraction, and a tangible reduction in proteinuria, which is a key marker of ongoing kidney damage. Of course, we still rely on foundational therapies. Renin-angiotensin system inhibitors, our ACE inhibitors and ARBs, remain the cornerstone for many of these patients. By blocking this key pathological pathway, they effectively lower blood pressure, reduce the workload on the heart, and provide essential long-term preservation of kidney function. They are the bedrock upon which newer therapies are often built. Finally, let's talk strategy, not just a specific drug. With diuretics, the goal is precision. We're aiming for euvolemia, that perfect fluid balance. This isn't just about aggressive diuresis, it's a guided approach to decongest the kidneys and relieve systemic volume overload without causing an acute kidney injury. Success here depends on astute clinical assessment to find that therapeutic sweet spot. These 4 pillars represent a huge leap forward in our ability to manage this complex syndrome. But implementing them in a patient with fragile hemodynamics and borderline renal function, that's a different challenge altogether. Are they as simple to use as they are effective?
The large-scale trials we've just seen give us a powerful roadmap for treatment, but translating that evidence to the bedside of a fragile cardiorenal patient, that's where the art and science of medicine truly intersect. Every one of these powerful tools carries inherent risks that we must anticipate and manage proactively. Take aggressive diuresis, for instance. We desperately need to relieve the heart's volume overload, but there's a fine line between effective decongestion and causing harm. If we push too hard or too fast, we risk tipping the patient into a pre-renal acute kidney injury by dropping renal perfusion. In practice, this means constant vigilance, monitoring urine output, daily weights, and electrolytes to avoid hypotension and dangerous imbalances like hypokalemia. Similarly, with RAS inhibitors, cornerstones of heart failure therapy, we often see a transient and frankly expected rise in creatinine upon initiation. The key is not to panic. We've learned that a small bump is often the price of admission for long-term cardiorenal protection. However, we must monitor for significant creatinine elevations or the development of hyperkalemia, which requires immediate action. It's a classic case of starting low, titrating slow, and checking labs frequently. Then we have the SGLT2 inhibitors, our transformative new players. While their benefits are profound, they introduce unique challenges. The risk of genital mycotic infections is real and requires explicit patient counseling on hygiene. More seriously, we must be alert to the possibility of euglycemic DKA, especially during intercurrent illness. Their diuretic effect also means we have to be mindful of overall volume status, particularly when used with overdiuretics. Finally, all these therapies converge into the complex problem of polypharmacy. The typical CRS patient is often taking 10 or more medications. This dramatically increases the risk of drug-drug interactions and the cumulative burden of adverse events. Beyond safety, a complicated regimen can overwhelm a patient, leading to confusion and poor adherence. A perfect therapy plan is useless if the patient can't follow it correctly. We see the proven benefits and we see the significant risks. On one hand, we have guideline-directed medical therapy, on the other, a minefield of potential adverse events. So how do we navigate this complex terrain? How do we personalize these powerful treatments to maximize efficacy while ensuring patient safety?
Every therapeutic decision we make in cardiorenal syndrome is a calculated risk. It's never just about efficacy, it's about the trade-offs. Here, we can quantify that balance for our cornerstone therapies, looking at the numbers needed to treat versus the numbers needed to harm. The SGLT2 inhibitors have been transformative. In practice, this means that for every 21 patients we treat for roughly 2.5 years, we prevent 1 heart failure hospitalization. That's a significant clinical impact. But there's a known trade-off. The number needed to harm for a genital mycotic infection is somewhere between 10 and 20. While this is a manageable side effect, it's one we absolutely must counsel our patients on before initiation. The story is similar, but the numbers and risks shift when we consider mineralocorticoid receptor antagonists. The data shows we need to treat 32 patients for 1 year to prevent 1 cardiovascular death or heart failure hospitalization, a very powerful outcome. The caution here is hyperkalemia. The number needed to harm for hyperkalemia severe enough to require stopping the drug is just 12. This highlights the critical need for vigilant potassium monitoring, especially when initiating therapy or adjusting other medications. RAS inhibitors, our ACEs and ARBs, present a different kind of balance. Their key benefit is a substantial absolute risk reduction for chronic kidney disease progression, sometimes up to 20%. But we all know the challenge, that initial transient bump in serum creatinine we see in 10 to 20% of patients. This often causes clinical anxiety, but it's usually a hemodynamic effect, not true nephrotoxicity. Understanding this is key to staying the course for long-term renal protection. Finally, there's intensified diuresis. Its primary role is providing rapid, essential symptomatic relief from congestion. But aggressive diuresis is a direct path to acute kidney injury if not handled with care.
The number needed to harm for AKI can be alarmingly low if we aren't individualizing the strategy and constantly assessing volume status. It's a powerful tool, but one with a very sharp edge. These numbers give us population-level averages, but our patients aren't averages, they are individuals with unique risk profiles. The crucial question then becomes, how do we apply this evidence to select the right therapy for the right patient at the right time?
That delicate balance between efficacy and safety we've just discussed becomes most critical when we're deciding which therapy is right for which patient. The evidence is now overwhelming on one particular group. Individuals with established heart failure and concurrent chronic kidney disease, specifically an eGFR below 60, derive truly substantial benefit from SGLT2 inhibitors. These agents provide profound dual cardiorenal protection, and they have rightly become a cornerstone of our management strategy. It's not just about managing a symptom, it's about fundamentally altering the disease trajectory. Of course, our approach must be more nuanced with other powerful medications. For patients with more advanced CKD, or for those who have a known history of hyperkalemia, initiating or titrating mineralocorticoid receptor antagonists, or RAS inhibitors, requires a higher level of vigilance. This doesn't mean we automatically withhold these life-saving therapies. Instead, it demands a clear and proactive plan for closer laboratory monitoring, allowing us to manage a known risk while still delivering a clear benefit. Beyond the lab values, we have to consider the whole person. Factors like advanced age, frailty, and the burden of multiple other chronic conditions are powerful determinants of treatment tolerability. An aggressive regimen that is perfectly appropriate for a robust 60-year-old could prove harmful for a frail 85-year-old, increasing risks for falls or adverse drug events. This is where true clinical artistry and individualized care are absolutely essential. To help us refine this individualized approach, we can turn to biomarkers. Think of NT-proBNP and high-sensitivity troponin as our biological early warning system. Elevated levels aren't just abstract numbers, they signal significant myocardial stress and underlying injury, effectively identifying patients on a steeper, higher risk trajectory. These markers help us pinpoint who needs our attention the most. The essential question then is, how do we synthesize all this information into a coherent, actionable plan in a busy clinic?
After identifying the specific patient who is at highest risk, the question becomes intensely practical. What do we do at the bedside? This is where we translate risk stratification into a concrete, hands-on management plan. The first and most critical step is to precisely define the problem. We must establish the exact cardiorenal syndrome subtype and its underlying driver. Is this an acute heart failure exacerbation causing acute kidney injury, a type 1 CRS? Or is it chronic heart failure slowly eroding kidney function over years, a type 2? The answer dictates our entire initial therapeutic focus. From there, our attention turns to volume status. The goal is achieving euvolemia, but this is a delicate balancing act. Aggressive diuresis might relieve congestion, but can also precipitate a further decline in renal function. In practice, this means careful, frequent assessments using everything from daily weights and clinical exams to point-of-care ultrasound, ensuring we don't tip the patient from volume overloaded into a state of intravascular depletion. With volume being addressed, we can systematically introduce guideline-directed medical therapies, or GDMT. This isn't a race. It's a thoughtful process of layering in medications like SGLT2 inhibitors or mineralocorticoid receptor antagonists. We must always consider the patient's current renal function and potential drug interactions, often starting at low doses and titrating upwards cautiously while monitoring their response. All of this requires a vigilant feedback loop. We need to monitor clinical status, renal function, and electrolytes with high frequency, especially in the early stages. This isn't a set-it-and-forget-it condition. We're looking for trends, not just single data points, allowing us to make timely adjustments and confirm our therapies are helping the heart without unduly harming the kidneys. This systematic approach forms the foundation of modern CRS care. But how consistently is this framework applied across different healthcare systems? And do the major clinical guidelines in the United States, Europe, and elsewhere all sing from the same song sheet?
Those practical management steps we just outlined are grounded in a robust global evidence base.
The consensus on how to treat cardiorenal syndrome is stronger than ever, with major cardiology and nephrology organizations largely singing from the same song sheet. The major cardiology bodies, like the American College of Cardiology and American Heart Association, along with their European counterparts, all powerfully endorse SGLT2 inhibitors and mineralocorticoid receptor antagonists. Their focus is on heart failure with reduced ejection fraction, but the key insight here is the recommendation to continue these therapies, even in patients with moderate chronic kidney disease. This reflects a paradigm shift. We're no longer stopping these life-saving drugs at the first sign of renal dysfunction. From the nephrology side, the KDIGO guidelines reinforce this approach, albeit with a kidney-first perspective. They champion the use of RAS inhibitors and, increasingly, SGLT2 inhibitors specifically for their proven renoprotective effects. In practice, this creates a powerful therapeutic synergy. Cardiologists prescribe a drug for the heart, and nephrologists recommend the same drug for the kidney. It's a clear win-win for our cardiorenal patients. Of course, the alignment isn't perfect. Where we see some divergence is in the fine print, specifically the precise eGFR cutoffs for starting a drug or adjusting its dose. This isn't a sign of conflict, but rather a reflection of different expert committees weighing the same body of evidence and arriving at slightly different risk-benefit calculations. The core principles, however, remain identical. And that leads to the most important point of all, one where every single guideline converges. They all stress that these documents are not rigid protocols. They are frameworks that demand individualized patient assessment. The complex interplay between the heart and kidneys in any single patient requires our clinical judgment. The guidelines give us the map, but we still have to navigate the terrain. So how do we translate this complex clinical judgment into a coherent plan with our patients? How do we ensure they are true partners in navigating these difficult choices?
Those global guidelines provide the map, but the real journey is navigated in the one-on-one conversation with our patient. This is where evidence becomes personalized medicine. And for cardiorenal syndrome, that conversation is everything. First, we must translate the complex pathophysiology into something tangible. I often describe the heart and kidneys as interconnected utilities in a house. The heart is the pump, the kidneys are the filter. If the pump weakens, the filter doesn't get enough flow. If the filter gets clogged, the system backs up and puts tremendous strain on the pump. This simple analogy helps patients grasp why we must treat both organs together. With that understanding, we can discuss our therapeutic strategy. It's crucial to be transparent about what to expect. For example, when starting a new medication like an SGLT2 inhibitor, I prepare patients for a possible temporary creatinine bump. I explain it's not a sign of harm, but a signal that the system is recalibrating for long-term protection. We'll also anticipate and manage potential side effects like hypotension together. This often leads directly to the topic of polypharmacy. Pill fatigue is a very real barrier, and we must acknowledge the burden. In practice, I find it helpful to reframe the regimen not as a long list of drugs, but as a comprehensive shield for their organs. Each medication is a specific tool defending the heart and kidneys from long-term damage, making adherence a proactive investment in their future. Ultimately, these discussions empower our patients to be partners in their care. Our job is to present the options and the evidence. Their job is to tell us what matters most to them. Is their priority avoiding hospitalization or being able to walk a certain distance? When we align our medical plan with their personal values, we don't just improve adherence, we improve quality of life. This individualized approach is our cornerstone. But how do we adopt this framework when patients have additional complexities, like advanced age or significant comorbidities? How do our strategies need to evolve for these diverse groups?
That conversation with our patient is just the beginning. The guideline-directed medical therapy plan we co-create must then be meticulously adopted to their unique physiology and life circumstances. This is where clinical judgment becomes paramount. In our elderly patients, this principle is front and center. They often face a trifecta of risks: polypharmacy, a greater chance of orthostatic hypotension, and kidneys that just don't clear drugs as efficiently. In practice, this means our dosing strategy must be conservative. The mantra, "start low, go slow," isn't just a saying. It's a critical safety imperative to prevent falls and adverse drug events.
What about patients with very advanced chronic kidney disease, for instance, an eGFR below 20? Here's where the nuance is fascinating. While SGLT2 inhibitors are generally not initiated for primary kidney protection at this advanced stage, their powerful benefits for heart failure persist. So the indication for the drug simply shifts. It's a perfect example of how the why behind our prescription can evolve with the patient's condition. Then we have the challenge of concurrent liver disease. This profoundly alters drug metabolism and clearance. Aggressive diuresis in a patient with cirrhosis, for example, can be a tightrope walk, risking severe electrolyte disturbances or even triggering hepatic encephalopathy. This is a scenario that demands extreme caution and often close collaboration with our hepatology colleagues. Finally, for pregnant patients, our entire standard playbook changes. Most of our cornerstone therapies, like ACE inhibitors, ARBs, and MRAs, are strictly contraindicated due to risk to the fetus. Management pivots entirely to maternal symptom control and safety, using a much smaller, select group of medications. This is truly the domain of specialized, multidisciplinary teams in high-risk obstetric centers. We've seen how complex these individual scenarios can be. So how do we distill all this into a set of core principles we can apply at the bedside every day? After considering how we tailor management for diverse populations, we can distill our approach down to a set of core, actionable principles. These are the pearls that should guide our daily clinical decision-making, regardless of the specific patient context. The first and most fundamental is to see cardiorenal syndrome for what it is, a dynamic bidirectional pathology. It's not just the heart failing and the kidney suffering as a consequence. It's a toxic feedback loop where each organ's dysfunction worsens the others. Our care must be just as integrated, bridging the gap between cardiology and nephrology teams. Accurately classifying the CRS subtype is our essential first step. This isn't an academic exercise. It directly shapes our strategy. The workup and initial therapy for type 1 acute cardiorenal syndrome, where acute heart failure causes acute kidney injury, are completely different from those for type 4, where chronic kidney disease contributes to cardiac decline. Proper classification sets us on the right path from the very beginning. From there, we must prioritize euvolemia. The goal is achieving that Goldilocks volume status, not too wet and not too dry. We walk a tightrope, using diuretics judiciously to relieve congestion without causing iatrogenic hypovolemia and renal hypoperfusion. Over-diuresis can be just as harmful as persistent congestion, so meticulous volume assessment is key. Fortunately, we now have powerful tools to protect both organs simultaneously. Implementing SGLT2 inhibitors and mineralocorticoid receptor antagonists, or MRAs, in eligible patients is a game changer. We've seen that these drug classes offer profound cardiorenal benefits that go far beyond their original indications. The evidence is clear. Early implementation improves long-term outcomes. Of course, using these powerful agents requires vigilance. We must monitor renal function and electrolytes closely, especially after initiation or dose changes. In practice, this means anticipating a small hemodynamically mediated rise in creatinine and not panicking. We need to distinguish this expected effect from genuine drug-induced kidney injury to keep patients on these life-saving therapies. These principles represent the synthesis of decades of clinical investigation. So where does this robust evidence base come from, and what are the landmark trials that inform these recommendations?
That brings us to the close of our discussion on cardiorenal syndrome, bridging nephrology and cardiology. We've covered a lot of ground today, from the foundational concepts through to practical implications. I hope the evidence and insights we've explored give you a solid framework to work with. I'd welcome any questions or thoughts you'd like to share. You can also access the slides using the QR code on screen. Thank you for your time and engagement.